Okay, so now I'd like to invite Dr. Amy Morrison to the podium to speak about her ongoing trial there in Iquitos, Peru. Okay, countdown, 3-minute warning, laser.
Okay, and do I?
Yeah, Thomas is going to.
He'll do it.
Yeah, there we go.
Okay.
Yeah.
All right. Well, thank you, Nicole. So basically, I'm going to just tell you about the ongoing RCT that we're conducting in Iquitos, Peru, which will be wrapping up in January. So maybe a year before we have, or end of 2019 before we have results, but we are really getting to the end. And I start by telling you a little bit about Iquitos. It's located in northeastern Peru, and it's a socio-epidemiological island. It's about 380,000, it's probably up to 400,000 now. And it is only accessible by air or river travel, which makes it a unique location for dengue transmission studies. The transmission history is well documented by the U.S. Navy in the city. They had their first introduction of dengue virus in 1990, and we've been working on cohort studies since 1999. So we've been able to characterize transmission dynamics effectively. We have been conducting entomological monitoring for that entire time, and we have a pretty long history of doing vector control efficacy trials, although I'd say this is actually our second RCT. Let me tell you a little bit about the design of this study. We have 26 clusters of approximately 150 houses. That's how they were designed. The city is divided into 34 Ministry of Health zones, and we formed our clusters by selecting blocks at random in 13 of those zones, building a cluster of about 150 houses. So that runs from about 1 to 6 city blocks will comprise a cluster, depending on the local space. And then we would essentially move the furthest location within that Ministry of Health zone to initiate or to build the second cluster. So we had two clusters within 13 different MOH zones. And you can see those locations. Let's see. You can see each of the different colors. This stippled area is another ongoing cohort study being carried out in Iquitos at this time. Essentially, oops.
Yep, maybe he can advance too if it doesn't work.
Okay.
Thomas, can you advance, please?
Thank you. This is just some photos of the device. It's actually an 8.5 by 11 plastic sheet coated with transfluthrin. And the approach that we've taken to deploy them, there needs to be a shield to cover every 9 meters squared. So our team, and I think I have some photos of this later. Go ahead and advance. There we are. Has a pretty unique way, and I'll show that in a little bit later. But as Tom pointed out, the endpoints for this trial are epidemiological. So we're measuring dengue virus or Aedes-borne virus transmission in 2 ways. We essentially have a cohort. So we invite everyone living on those blocks to participate in the study. And essentially all they have to agree to is a visit 3 times a week by our staff to ask if somebody has a fever. If they have a fever, we consent them to give a blood sample, and they would give us a second blood sample 14 to 21 days later, and this way we can identify clinically apparent Aedes-borne virus disease. Second, we have a subset of that group of children, pediatric cohort, where we take blood samples essentially annually. And then we can do a microneutralization test and identify seroconversions, which will include inapparent infection as well as apparent infection. So this is essentially two measures of transmission. The denominator for the active surveillance component is very large. We have about 17,000 people under surveillance. There's been a fair amount of turnover. And this cohort is about 2,200 people. So it's a much smaller denominator, but it's two distinct forms of measuring transmission. At the same time, we continuously monitor the Aedes aegypti population. Baseline surveys, we look at both larval indices and adult indices, but all subsequent surveys essentially are using a Procopec aspirator here. Well, actually, I have to click to vacuum out adult mosquitoes. And this is in our hands, a very effective way to measure the Aedes aegypti population. Now, let me show you a little bit about how these shields are deployed. We have a team of about 5 guys who are amazing, but they can measure the front side of the house, and essentially for anything up to 3 meters, they'll run an elastic line down the middle of the house. Up to 6 meters, it would be 2 elastic lines down the full of a house, because in Iquitos, most of the houses don't have closed roofs. They're open-eaved. So we can just literally hook up the elastic line the whole length of the house, and then we would start on one line and just using photo check clips, hook them up on the top. Now I've got some more pictures to sort of show this. So you can see sort of, and then we just make a little cylinder, clip it with the photo clip, and this is all kept track of in a cell phone application. So we know how many shields are in the house. We have an application to ensure that we have appropriate spatial coverage, and we can monitor replacements of those shields so that we need to replace them every 2 weeks. So 1,700 houses every 2 weeks. It's been a pretty big job. And here's just some more photos of the shields. And it really only takes less than a minute to do the replacement, as long as we have access. This is some pictures of the adult mosquito aspirations. You can see here, we use a ComCare, which is a commercially available service that uploads the data to the cloud. It's secure, and it allows our personnel to collect this very repetitive data over time. In addition, we use the ComCare app to monitor our surveillance visits so that we can actually document the fact that we are knocking on those doors 3 times a week and have solid denominator data for our infectious disease rates. And I think we've got a couple of the people who've built these apps here, so after I can introduce you to Anya and Will, who have done this. So just to give you, I can't really reveal too much. We can't break the code. That's something I also should explain, that we essentially receive 26, or not 26 boxes, hundreds of boxes with 26 different numbers. And each number corresponds to a cluster. And this is a double-blinded study. So 13 of those zones get essentially a blank. It has a solvent on it, and the other 13 clusters get active ingredient. And what you can see here is we'll show you that we have managed to identify active disease. We had a Zika outbreak during the startup of this study. So this is either excellent news or it could have just waited a few more months, but there was a lot of transmission, and I think this will give us the power, this will help give us the power we need to evaluate this tool. And again, I can say these were the cases that occurred during the actual deployment. So we took that first blood sample, deployed the shields, and then we started following our cohort. And then these are cases that we've picked up since then. And you can see this over time. In terms of our longitudinal samples, we are currently taking our third annual bleed. We've completed 2 annual bleeds, and this shows a little bit of the evidence. We will go back and look at every dengue serotype and Zika for all paired samples, because again, we want to identify a seroconversion, which means somebody without antibody and they develop antibody during that year period. And in terms of the entomology surveys, as of August, we'd conducted around 87,000 surveys, identified, and this was just in the baseline surveys here, these 19,000 containers, and up until now we've collected almost 150,000 adult mosquitoes. And I just pulled new data, so this is really an underestimate. We've collected a lot of mosquitoes, and we've actually done 60 rounds of these 2-week follow-up collections. What I did here is just to, this was earlier on in a preliminary analysis, but the blue bars represent the baseline surveys before deployment of the shields, and then I just collapsed survey data for post intervention, and this was really in the first few months after deployment. And what's encouraging is this decrease. This isn't necessarily what we would expect, but it is encouraging that you see that trend. And this is just some of the baseline people demographic surveys from the baseline surveys. Let's see. Could you advance? There we are. Another important thing that okay, good. No, another important aspect of this RCT is to be able to monitor adverse events, because this is a chemical product and we have the opportunity to measure this in both the control and treatment areas. And we've had to be sort of, I don't want to say clever, but we've had to take a number of approaches. One thing we do, and we're required to do in a human use study anyway, is report all deaths. And we've had 185 since the study began. And we really haven't, this information is sent to a data safety management board to see if they find any link to the shields. People do die in these cohort studies. We also monitor dropout rates, households that actually, ask to be removed from the study. And in this case, we only had 5 reasons that were given that were associated with a health effect. We actually had 26 reported adverse events, and this is a case of sort of an allergy, dry mouth, itching, or skin irritation, headache. And all of these, again, need to be reported on a quarterly basis to the Data Safety Managing Board. We also have some vasovagal responses when we take blood samples, and these were distributed across 11 clusters. Advance, please. Okay. The other really important issue is maintaining coverage. If we don't have the product in place, we're not protecting our population. And Will Elson has done a lot of work. Could you advance it to, again, you can sort of see the structure of the cluster. And this is some data where, again, we have about 1,700 houses mean per round. You can see we've maintained about a coverage rate of 82%, which I think for those of you involved in vector control, not bad. And it takes a lot of effort. And I think I'm running out of time, so I'm going to advance. And this just illustrates from Will, again, our essentially the temporal pattern of coverage. It took us a while to get things deployed, and we had a little chaos in the beginning, but then we really hit our rhythm. Advance. We've also monitored insecticide resistance, so we have what was called a genetically diverse laboratory strain that we can use as a control that was developed from 10 colonies coming from different spatial areas in Iquitos, including where the clusters are. And these are maintained in our laboratory in Iquitos. And then after a year, we pulled the eggs from each of the clusters. They were pooled with the help of our data safety managing board. Again, we have to always think about blinding and maintaining our lack of knowledge of which clusters have the shields and not. But the take-home message here is that we are seeing some development of resistance in bottle assays, and so we'll do this again at the end of the study. And next slide. And finally, another thing that we're doing is a self-administered shield perception questionnaire. It's a small 12-question survey that we hand to residents to ask them, do they feel more or less mosquitoes? But the idea, again, is to blind us from their responses. So somebody teaches them how to use the app, and there's always some kid who's very good at it, so we can get it done. And also, this is a way to see how people feel about the product. And what you can see is that about 60% of the people answering the survey indicate that they feel like they're being bitten less, and about 52% feel that there's fewer mosquitoes. 40% say they'd pay for repellents, but 83% would recommend them. And again, just discussing this with the population, there has been a pretty good uptake, but it is labor intensive, the switching out. And I just stop there, thanking our research team. They're really amazing, and our collaborators at the Naval at NAMRU. Without them, this couldn't be taken care of. So I'll stop there.
Thank you.